Okay, so we're going to pick up with asthma. Asthma, as it says, is an episodic disease. It's been a bad word day for me. Meaning episodes. There's something taking place that is an episode. You have running, exercise, you have the climate, you have pollen, you have stress. You have these different things that can sort of bring on a true asthma attack when we start looking at it. By definition, the asthma attack, it narrows the bronchioles, and you still get this overproduction of mucus, and it traps the air in. So asthmatics typically don't have a problem getting the air in. They have trouble getting the air out, which causes the wheeze. Okay? So, like I said, allergic reactions, pollutants, especially people with asthma, bad asthma, that usually, where the weather guy comes on and he says, hey, this is an orange day, right? It's not a healthy day for people with respiratory problems to be out. So they would stay in. Exercise, stress, like we talked about. So there's a number of different things. Twice a year, asthmatics usually have a big problem when we turn on the heater and we turn on the air conditioner, because all that dust and all those dust mites in the ventilation system blows out and asthma takes place. Stress-wise, I've seen like true asthma attacks, bronchospasms with stress because of report cards. Mom and dad cranking down on their child because of the report card, and that stress that builds up causes an asthma attack. When I say a true asthma attack, okay, we look at that. If we go back and we think about a bronchospasm, remember we can see that on the cardiac monitor, not on the cardiac side, but on the monitor if it's has the ability to see end-tidal CO2. So if we monitor the end-tidal CO2, all right, the normal, and this is sort of my poor drawing, okay, but on the waveform, but it's sort of squared off like this, correct? And so you have inspiration, you have a pause, and you have exhalation, okay? In a bronchospasm, you have a shark tooth or a shark fin, okay? See if I can draw that. So in a bronchospasm, you have something. Ooh, that's not good. Okay. Anyway, that looks similar to that. Picture a shark tooth or a fin, and that's how they actually refer to it as a shark tooth. This would be sort of a normal inhalation, the pause in between inhalation, exhalation, and then exhalation. In a bronchospasm, when you monitor end-tidal CO2, you get a shark tooth waveform. And then that way you know that patient is having a bronchospasm. If they were hyperventilating, then you would get, when you monitor end-tidal CO2, you get a lot of these normal-looking waveforms, just a bunch of them. They'll be pushed together. Okay? The same way with these shark tooths. Someone having an asthma attack, a bronchospasm, and their respiratory rate is up, these shark tooths would be pushed together. There'd be a lot of them there, okay? Anyway, that's what I mean by an actual true asthma attack. With stress, a lot of people hyperventilate. They're not having an asthma attack. They're hyperventilating. Yeah, instead of having a bronchospasm. I forget which video this is. It was one of the asthma videos, but you sort of see the problem that takes place with asthma is that you have a normal bronchial here. So you have a muscle layer of that bronchial, you have a mucosa layer, and then a lumen or an open area, right, of that bronchial. What takes place in an asthma attack It's a release from these mast cells of histamine. Now, it sounds a lot like an allergic reaction with the release of histamine, the bronchoconstriction, the increase in mucus production. All that sounds a lot like an allergic reaction, but it is different. It's totally different. You wouldn't treat, even though you have a release of histamine from this mast cell with this asthma attack, you wouldn't treat this with Benadryl. Benadryl negates the effects of albuterol. So if you treat this, you wouldn't have, your albuterol would be useless. It'd be like water, okay? So even though it does release the histamine, and the histamine is what's causing a lot of the problems, we wouldn't treat that like an allergic reaction. We'd treat that with a beta-2 agonist like albuterol, a bronchodilator. Just the same as emphysema, okay? Treatment is really almost the same. So when we look at it in an asthma attack, because of the release in this histamine, now we have some swelling of that muscle layer. We have overproduction of mucus and a narrowing of that bronchial. So that's where we get the wheeze and the exhalation is because all that mucus and that muscle layer is sort of squeezing down that bronchial. So the primary treatment for an asthmatic is albuterol. Okay? We talk about Atrovent. We didn't talk about it in the emphysema part, but Atrovent, you mix those two together. So you have albuterol and Atrovent. Atrovent, or it's called an A when you mix them together. But Atrovent helps on drying those secretions. It's still classified as a bronchoconstrictor, bronchodilator, but we use it primarily when we mix it with albuterol to dry up those secretions, help dry up the secretions. So we'd start the patient on a nebulized albuterol treatment, 6 liters per minute. We'd coach him on how to breathe that albuterol in and try to hold it in. Continue to monitor the airway, continue to do a good assessment. But their sample and our OPQRST, continue that assessment and reassess. The muscle layer on the ALS side or at the hospital, they will give the patient steroids to start decreasing that inflammation process, and then continue to give them albuterol. They could they put them on CPAP if that's what they need. Okay, but typically with these asthmatics, they can fix this with albuterol and the steroids. Okay, they take care of the problems and make sure that they're outside of then stop whatever they're doing, the episode that they're doing to cause the asthma attack. And so the same sort of picture here, you see the edema in here, the accumulation of that mucus, right? The narrowing of the bronchial. We can fix all that with the medication quite easily most of the time. The problem with asthmatics where we have a more difficult time treating asthmatics is when they wait too long, okay, to call for help. Okay, so asthma is pretty quick. Okay, so because it's just sort of an extension of the emphysema part that we talked about in the last video, but I want to go back over the treatment again. So you have this asthmatic patient, okay? Good assessment. Start them on you listen, you auscultate wheezes. Start them on albuterol at 6 liters per minute. With this being an EMT class, that would be and then transport would be your treatment, okay? And just remember, when they get to the hospital or the ALS setting, they're going to get steroids for the inflammation. That usually takes care of it. Pneumonia, sort of the next respiratory problem that we have. When we look at pneumonia, the patient's short of breath. This is with or without exertion, okay? Most of the time without exertion, they have a cough, and usually that cough is productive, meaning that when they're coughing stuff up, and you get the discoloration like there's an infection, right? So they have a productive cough. Fever, and the chills come with the fever, okay? But when you're looking at this in patient care and also on the test, the fever is the key thing that you're going to see. Because what will happen is this patient can start looking a lot like a CHF patient, especially on a test question. When they start adding in all those distractors, they can look more like CHF. But when you get down to the fever, that's what separates them from the CHF. The pneumonia patient can have rales and rhonchi as well, okay? So you start thinking, oh, CHF, until you get down to the fever part. And then you know that, like, hey, they have this productive cough, they have fever. This is sounding more like pneumonia. They can complain of chest pain, and remember, typically, respiratory chest pain is sharp in nature, and it increases with inhalation. So as the patient inhales, they breathe in, the chest pain goes up, all right? The pain increases, and it's pleuric or pleurisy, meaning that it's pinpoint pain. Pleurisy is a thing that when you look at it, the two linings, the visceral and the parietal pleura, there's a fluid in between there. And every time we take a breath, that fluid is what lubricates those two linings. What happens with pleurisy is, and it's different than pneumonia, but it's pleuric type pain in pneumonia, is that fluid dries up, essentially, okay? And it's pinpoint. So this patient with pleurisy, they're saying, every time I breathe in, it hurts right there. That's what they mean by pinpoint pain. So they go, right there. Okay? And if they follow that line of having an infection, like fever and chills and, not feeling good, a little difficulty breathing, then they may have pleurisy as well. Okay. Other type of things, headache, diaphoresis. They get fatigued because they're not diffusing. Remember, they have that sort of that infection in their lungs, the pneumonia. And it's just like CHF, that fluid, it's hard to diffuse across that. And then the confusion comes from maybe they have a little hypoxia. So when we go to treat pneumonia, on the EMT side, it's mainly supportive care. What we want to do is we want to evaluate the need for oxygen. So we look at the SpO2, we look to see if they have any external, outward signs of respiratory distress. We can provide oxygen if they do. Not on the EMT side. It's outside the scope of practice for most EMTs, but we can treat pneumonia with albuterol or Ventolin. Okay? Open up those bronchioles a little bit, help them to breathe a little bit better. Okay? And then when they get to the hospital, they will get an x-ray. I don't think I have, can I take the picture down? Yeah. I had a picture where they can actually see the pneumonia. So they'll shoot a chest x-ray and they can see the pneumonia, and then they'll start them on antibiotics, depending on what type of pneumonia it is. So they'll start that patient on antibiotics. So we would transport, supportive care, provide oxygen, potentially albuterol treatment. Hospital, they're going to shoot an x-ray to confirm the pneumonia. They could have bilateral pneumonia, so pneumonia in both lungs, okay? Start them on antibiotics, and either sometimes they discharge them, like with what they refer to as a walking pneumonia, okay? Or they put them in the hospital and do IV antibiotics. So pneumonia is easy to treat a lot of times, and it's also easy to distinguish between the other respiratory problems because of the fever. Questions? Everybody good? Everybody good on pneumonia? Okay. The other respiratory problem that we'll talk about is the spontaneous pneumothorax. It's different than a tension pneumothorax. Remember, a tension pneumothorax is life-threatening. A spontaneous pneumothorax, like it says, it's still a collapsed lung, okay? The lung, or the slang term, collapsed lung, but it comes from a lot of smokers. What takes place with this smoker is they develop blebs, B-L-E-B-S, blebs, and those blebs rupture. The best way to describe it is those alveolus, because of the smoking and everything, they melt sort of together, and then they rupture, and when they rupture, they cause injury to the lung, where they get a pneumothorax. Now, it's not like a tension pneumothorax. You see that sort of a sudden onset, and everything is accelerated because of the trauma. In a spontaneous pneumothorax, like a medical case with the smoker or whatever caused the pneumothorax, it's more of a gradual onset. The patient's still going to have most of the signs and symptoms of a tension pneumothorax. Okay, and I kept the picture of the pneumo, but not the pneumonia. Okay, so there you can see sort of the white area here on the x-ray and the black area there. That's where the pneumothorax is. What happens in a tension pneumothorax and a spontaneous pneumothorax is the injury to the pleura. Air escapes outside the lung into the pleural space, and it starts collapsing or pushing that lung over. In a spontaneous pneumothorax, it takes a lot of time for it to actually do that, but it'll start pushing that lung over. So you're going to have a patient that's presenting with shortness of breath, okay, because they're not really using this lung very well in respiration. Okay? So one of the signs, if we look at it, is decreased or absent breath sounds on the affected side. So in this x-ray, you have good breath sounds over here, and then you have absent or decreased breath sounds over here. But keep in mind, a spontaneous pneumothorax is a medical condition. In the hospital, what they will do is that they will insert a chest tube, remove the air. They're going to do the same with the tension pneumothorax. They're going to insert the chest tube and remove the air, and then allow time for this to heal itself. So you're looking at this patient here is probably looking at a 2 to 3 day stay in the hospital with the spontaneous pneumothorax. So signs and symptoms, we look at this, sharp, back to that pleuric pain. Like we said, decreased or absent lung sounds on the injured side. Shortness of breath, especially with the exertion. In the later stage, like always, in a spontaneous pneumothorax, you would get your sats will start to drop and you get cyanosis. You get the tachycardia because of the fact that you have the increased respiratory rate. So you have this sort of, the respiratory rate's going to go up, they're going to get short of breath, they're going to get tachycardic, they're not going to be able to breathe out of that one side. Okay? And when you do your assessment, you'll see that sharp pain with inspiration. You auscultate breath sounds, and then once you see the decreased or absent breath sounds, you're pretty much assured that they have a pneumothorax. Okay, pneumo meaning air, thorax. Okay, so EMT treatment on a spontaneous pneumothorax would just be, provide airway support, oxygenate, and transport, like we just talked about in the hospital. They're going to insert a chest tube, get the air out, and allow the lung to repair itself. CPAP is contraindicated. That's the big thing with the spontaneous pneumothorax, because the fact that, remember, CPAP, continuous positive airway pressure, will force air into the lungs. So when it's forcing that air into the lungs, it's going to make the pneumothorax worse. In a late sign of even a spontaneous pneumothorax, remember you get the tracheal deviation, the JVD. Okay? So all the signs and symptoms really go together. It's just in a tension pneumothorax that all takes place within minutes, where I've seen a person with the spontaneous pneumothorax for like hours. Questions there? Everybody good? All right. So let's talk about the big and nasty one, the pulmonary embolism. So what happens here is people who have a pulmonary embolism, usually that it's from a clot or a thrombosis breaking off into another part of the body, right? Like a DVT in the legs. That's why they're telling you on the international flights that you want to get up and walk around a bit. People that are in the hospital for a while, like post-surgery, remember the PCT stuff? They put those subsequential compression devices, the SCDs on them, and it massages their thighs so they don't develop clots. Right? So what happens here, from the DVT, the clot breaks off and it travels and it just happens to end up in a pulmonary capillary. So it causes a blockage. It's a huge VQ mismatch. We went over this when we in the last respiratory video, but it causes a very large ventilation to perfusion mismatch. So if the patient's able to breathe air in, but because of the blockage, they're not able to diffuse the air or the perfusion part of it. Okay. And that is mainly the cause of a pulmonary embolism. It's life-threatening. The patient has just this sort of sudden onset of severe respiratory distress. That patient's going to, when you see them, initially they're going to be sitting sort of bolt upright, and severe respiratory distress, tripoding, accessory muscles, trying to breathe, right? And you put a non-rebreather on them, and 10, 15 liters per minute, and they're still sitting bolt upright, having trouble breathing because of the embolism, the VQ mismatch. They're getting plenty of air in, they just can't use it, okay, because of the blockage of the pulmonary embolism. Most of the people that I have taken care of with PEs have not survived it, because what takes place is they have such a hard time breathing because of the embolism. They have a heart attack, they have an MI, and most of them have a global MI, which means that they infarct every section of their heart, inferior, anterior, right? They infarct all the sections of their heart. So they end up really dying from a heart attack, but it's secondary because of a pulmonary embolism. So chest pain, severe shortness of breath, you will see the drop in saturation quickly with the embolism. Cyanosis is still sort of a late sign. The tachycardia, wheezing due to the blockage, okay? And once you see one, then they all look sort of the same. Okay? It's that scared sort of bolt upright sitting that they have that they can't breathe, right? So our treatment for an embolism varies depending upon your scope of practice. You try to oxygenate them, okay? They need to get to the OR or the cath lab very quickly, because if we go back here, they have to remove this clot. So they can either do that in the operating room, or they can go to a cath lab and they can remove it in the cath lab. Okay? But they need to very quickly get to the cath lab or the OR. Like we said, most of them die from AMI. It's because of this VQ mismatch, ventilation to perfusion mismatch. So pre-hospital, even on the ALS side, all we can do is oxygenate them. They desperately need to go to the OR or to the cath lab. Okay. They can also just not from the DVT, but they can get a pulmonary embolism from amniotic fluid. Okay, they can get pulmonary embolism from air, like in trauma when we talked about neck injuries and have those big lacerations on the neck. The air gets inside there and it forms an embolism. Okay, the clot, the air, the amniotic fluid, it just seems to stop in those pulmonary capillary beds. But if it happens to get in a coronary artery for somehow, then the patient's going to have a heart attack, right? If for some reason the embolism makes it past the respiratory system and lodges in a cerebral artery or vessel, then the patient's going to have a stroke. Oh, okay, I did leave that on there. Questions about pulmonary embolisms? It's quick, down and dirty, but it's what it is. Okay. Epiglottitis. Epiglottitis is typically a childhood disease. So you're going to see this patient got this sore throat, the drooling, the difficulty swallowing. Remember the itis, it's the inflammation of the epiglottis. The epiglottis is that leaf-top structure that goes over the glottic opening that protects the trachea from when you swallow food and water. Okay? This patient's going to be up sort of a tripod, drooling. When you look at them, you use that pediatric assessment triangle, they're going to look sick, right? the thing with epiglottitis, sort of the key factors that we look at, is they have a sudden spike in temperature. Especially on a written exam, you're going to see that. They're going to describe it as the patient, little boy sitting up, tripod, drooling, and had a sudden onset of fever or a sudden spike in temperature. That's going to be the key term here when you're trying to decide if the patient has epiglottitis or the patient has croup. Those are the two childhood things on like exams that you have to discern. It's easy. Even with real patients, outside of the exam time, epiglottitis is going to be more of a sudden onset and a sudden spike in fever. And they always see to put this drooling part in there as well on test questions. But croup is going to have that seal top bark, and it's going to be more of a gradual onset. So a croup would be a patient that has been feeling sick and for days, and sort of has this, when they cough, they have this seal type bark to them. Okay, that's sort of the difference between croup and epiglottitis. Our treatment for epiglottitis, because it's life-threatening, we don't want that epiglottis to swell and occlude the glottic opening, right? Then you would have to have someone come along and do a surgical airway. We don't want that, okay? So keep them calm, keep them comfortable, don't inspect the throat, administer oxygen as long as it doesn't upset them. Don't do anything that upsets the patient. In the EMS environment, we would, like the small child, we would let them ride on mom's lap. We don't do anything that upsets them. Alert the hospital that we have a possible epiglottitis. You're going to probably see a different doctor than what you're not used to seeing when you get to the ER, because usually if you tell the emergency department that you have someone with epiglottitis, they're going to call anesthesiology, because they don't want to mess with that either. Okay, they don't call someone, a specialist, in if they have to intubate the child. And then they won't do too much at the hospital as well to upset, because they don't want upset the child, because they don't want the epiglottis to swell either. But they're in a better position there to get the child intubated. But do remember those differences between epiglottitis and croup. And then we just have a few. Hyperventilation. So you get someone that's upset about something, a lot of anxiety, they start to hyperventilate. We talked about that just a minute ago with asthma, how we can tell the difference if we do the end-tidal CO2 monitoring. Okay, usually patients with hyperventilation you need to talk them down, take them out of the environment that's stressing them out, making them hyperventilate. Hyperventilation syndrome, on the ALS side, we give them like an Ativan or something to relax them. And then usually attempt to talk them down. No more do we do the brown bag, or the non-rebreather without hooking it up to oxygen. That was like decades ago. They took that away. The brown bag, even though it does work, because what happens is the patient that's hyperventilating is blowing off too much CO2. So you're going to have this patient that starts to cramp up in their hands. Their hands are going to start cramp and start constricting or contracting. They're going to have chest pain with this, and all that goes away once you get them to slow their breathing down and their CO2 comes back to the normal limits. Because when they're hyperventilating, they're expelling too much CO2, and that causes all the negative things with hyperventilation. Cystic fibrosis, genetic overproduction of mucus. So you're going to have this child here that is very wet. Okay, have a lot of mucus production. It's a chronic thing. So our treatment there would be to oxygenate. Pertussis or whooping cough, this uncontrolled cough. You see these things in these childhood diseases. If you guys go to work for like a children's or something, you'd see this stuff all the time. Okay, but ours would just be supportive care, okay? Transport, supportive care, airway control, suction, maybe RSV. A lot of production in mucus, fever, cough, and you look at about a 14-day period. Every year, the pediatric crowd goes through RSV. Okay, and a slight interesting note, and I haven't really looked into it that much because I lost interest, but in all this COVID stuff, the RSV used to be just to the pediatric population. Now adults are starting to acquire RSV. And so that's a bit of a problem because it's usually only a pediatric emergency, but now they're starting to see adults with RSV. And then bronchitis, okay, inflammation of the bronchioles. A lot of people have trouble with that during the winter months where they have bronchitis. It resembles a pneumonia a bit with the signs and symptoms. You get the fever, get the cough, maybe a mild shortness of breath, not a big shortness of breath, okay? But that's treated very easily with antibiotics. So you do have some other just common infections and stuff. Epiglottitis is not that common. Croup is very common. That would go along with the pediatric crowd. Questions there? Anything? Okay, good. We'll stop for now.